Please welcome Dr. Chara.
Thank you. Thank you so much. I really think these events are so important. I recall this patient who I came with smoldering myeloma who was in her 80s, and she came by herself, and she didn't know her medications, and she just came and I said, look, you are the person who's seeing all these different doctors. You got to know your meds. You got to know what the problems are. And we need caregivers, nurses. I had the pleasure yesterday of speaking at Oncology Nursing Society, and it really takes all of us, and I applaud you all for coming, and the caregivers in particular. So I've been tasked with the relapsed refractory myeloma. So here's our patient case. 65-year-old concert violinist is diagnosed with myeloma, receives Revlimid, Velcade, and dexamethasone, RVD, followed by a transplant and Revlimid maintenance. 2.5 years later, her myeloma markers are increased, and she has persistent left leg discomfort. So the question for you is, which of the following factors is the least important consideration in treatment at this point? A, amount of neuropathy she has or could develop. B, her concert and travel schedule. C, genetics of her myeloma at the time of diagnosis. D, left leg discomfort. Or E, all of the above are important considerations. Okay. So it's an interesting response. And let's see if those who answered number 2, whether there are other choices or not, or if that's how important that is. So let's do some definitions, and I think we throw these around in clinical trials, but they often aren't well defined. Relapse means myelomas recurred after having had a response to therapy. Refractory means progression is occurring of the myeloma while on active therapy or within 60 days, which is what our consensus criteria state. And then another important term is line of therapy, which is a change in treatment either due to progression of myeloma or due to unmanageable side effects. The one exception here is initial or induction therapy with transplant, consolidation, and maintenance is all considered one line of therapy because there was no progression at that point. So when we look at, the reason these are important is when we look at clinical trials and various drugs for treating relapse disease, they're often segregated by these components of how many lines of therapy has the patient had. And this is what we're talking about. And so when I was in med school about 25 years ago, this table of drugs was basically the first 2 columns. And now we've added 4 new columns, so we can go from the left to right. Steroids, everybody's favorite. Conventional chemotherapeutics, melphalan and cyclophosphamide, also Doxil. We'll talk a little bit about these 96-hour chemo regimens called DCEP and DPace. Carmustine, old drug, not as commonly used, bendamustine. And then came thalidomide, which came because of a patient advocate. Actually, one of our colleagues, Bart Barlogi, who was at Arkansas, this patient's wife, he had exhausted all therapies and advocated for a novel agent, found that thalidomide had some interesting properties that led to its study. Didn't work for that patient, but that study then led to now $1 billion market. And it was, again, because of a patient advocacy effort. So we really need everybody to do this. There's now 3 proteasome inhibitors, Velcade, Kyprolis, Milaro, an HDAC inhibitor called Farad, and then 2 monoclonal antibodies, the Implicity and Darzalex. And so if you're thinking about the options, you can see this is really, it's great to have all these options. We still need more. And then when you try to put it together, this slide gives one type of schematic of how to approach it. But you can see it's very busy. And while there's some important questions that we should ask, I think I like this next slide better. But because at the end of the day, when you're thinking about treating somebody with relapse disease, there's essentially 3 categories of issues. Patient issues, so age, how functional is this patient? In our patient's case, she's a concert violinist. When you have all those drugs on that table, do you need to have her change her work schedule and her really what brings her passion in life if you have alternative options that are oral? Kidney function is very important. These are how kidney and liver are how most of the drugs are cleared, and 1/3 of myeloma patients can have kidney dysfunction. So that's going to whittle down that list of 6 classes of drugs to potentially few preferred agents. Low blood counts can affect our choices of drugs, neuropathy, other medical problems like cardiac disease and diabetes. And then we have disease factors like the risk of the patient, the genetic risk, cytogenetics. You heard from Dr. Cole, deletion 17p, 414. Also, what kind of relapse is this? In our patient, she was having leg pain, suggesting maybe this has clinical symptoms. But there are other patients who can have what's called a biochemical relapse, where the numbers are going up, but there's no CRAB symptoms. Calcium, renal function, anemia, bone, those are all fine. And how you approach those patients might differ. Is there myeloma outside of the marrow? Well-behaved myeloma typically is dependent on the marrow. Once you start seeing extramedullary sites and soft tissues coming outside the bone, that's more aggressive, and those patients need more aggressive therapy. And then the third category is treatment factors. So as I alluded to, what are this patient's preferences, and what are the previous therapies she's had, how deep was the response, how durable was that response, what are our routes of administration, is this going to be a single agent or combination therapy? Very important is cost. We all know in this room that can be very difficult for patients, especially the oral medications. Toxicity, blood counts, neuropathy, blood clots, secondary cancers. So going back to basic math questions that we would be asked in school, what are the different combinations? So when you take 6 different classes of drugs with multiple drugs within each class, you multiply those times all of these factors. The reason I skipped over those last 2 slides is the combinations are really too many. You can't have a prescriptive, first you do this and then you do that and then you do that, because the reality is there are going to be no 2 patients with the exact same features in terms of what therapies they've had, what their personal preferences are, what their disease is like. And that's the art and science of medicine. And I would argue, you could sometimes, why aren't these drugs being given by your primary doctor? It's because it's too specialized an area. If you don't give enough, you're not going to control the disease. And if you give too much, you're going to cause harm. We call that in medicine a narrow therapeutic index. So putting all of this together requires really a lot of attention to detail. And I think, as others have said, this is why we need, it's great to have a doctor close to home for convenience, but periodically it's really worth going to the larger academic centers for consultation and co-managing, ideally clinical trials as well. So first question is, when did the relapse occur? Was it within 6 months? That kind of tells us that this particular patient's myeloma is not sensitive to whatever they were getting. 60 days is obviously even worse. That's considered refractory. But even 6 months in you could think of as not that durable a remission. More than 6 months, you could potentially repeat what the patient was getting before. Transplants can be given, as Dr. Wiesel outlined, in clinical trial. But at a high level, in somebody who's relapsing, we have some of these backbone drugs shown in the green square, which is Velcade, Revlimid. This patient has had those before, and she was on Revlimid maintenance. So that's going to affect a lot of our choices. And then we have these other backbone, Kyprolis, Simplicity, Ninlaro, Darzalex. And usually the bottom 4 are given with Revlimid. So Kyprolis, Simplicity, Ninlaro, and Dara are combined with Revlimid and dexamethasone. But if that's if the Revlimid is not the appropriate backbone, you could also substitute in things like Pomalyst, Farad. So again, there's a lot of options, and too many to go through the combinations. But at a high level, the purpose of this is just to give you a little bit information about each of the drugs. So Kyprolis, or carfilzomib, is approved alone and in combination with dexamethasone, with Revlimid as well. It's given intravenously, and although it says the initial approved schedule was 2 days back-to-back, so say Monday, Tuesday, Monday, Tuesday, Monday, Tuesday, then a week off. Now there's weekly regimens that have been shown to be very effective and tolerable. Shingles reactivation is a side effect of the entire drug class with Velcade, Kyprolis, and Ninlaro, so all of those medications should be given with concurrent shingles prevention pills. As Dr. Kaufman mentioned, even if you got the Shingrix vaccine, because myeloma patients don't always respond as well to vaccines as healthy patients do, we can't depend on the vaccine when somebody's on these drugs that are known to reactivate shingles. 20% or 1 in 5 patients can have shingles reactivation, so rather than taking that risk, it's better to take these pills. If somebody's on an IMiD-based drug like Revlimid, there's a 20% risk of blood clots, so blood thinners should be also given. And the side effects are shown here on the right, and it's like those TV commercials where they list off 20 million things, and when we do clinical trials or when you hear these, all of these are listed, but for the vast majority, we can, the risks of these, all of the drugs that we're going to cover are usually outweighed by the benefits, but as an individual patient, we have to address that after each cycle, especially at the beginning, to make sure that these are not occurring. But these can include fatigue, anemia, decrease in blood counts, usually not that much with this agent, fever, and blood pressure can go up with this, so it's important to keep an eye on your blood pressure and very rarely cardiac issues, less than 5%. Nilaro, which is the oral proteasome inhibitor, it's approved in combination with Revlimid and dexamethasone. It's given once a week, 3 weeks on, 1 week off. Same principles of shingles and blood clot prevention. Because this is an oral medication, there is a possibility of more having GI issues, but generally, again, very well tolerated: diarrhea, constipation. Neuropathy can be seen with these drugs, but again, usually manageable. And then the other side effects as listed. And implicity is it's interesting because not until 2015 did we have a single monoclonal antibody. What's great about these monoclonal antibodies, and you'll hear a whole segment later about immunotherapy, but a lot of the drugs that we use not only kill the cancer but can cause side effects to the normal body. And so that's essentially the risk-benefit profile that we're navigating. What's cool about these immunologic agents are they help kill cancer, but they spare the body of a lot of those side effects. And so this particular one is improved in combination with Revlimid and dexamethasone. It's given weekly for the first 8 weeks or 2 months, and then it goes to every other week. There's some newer data to going to monthly dosing with this as well. We give pre-medications. One of the unifying principles with immunotherapies are they can cause sometimes allergic side effects because these are proteins, they're foreign proteins that are being administered, and so the body can have some allergic reactions. Typically, it's that first infusion, and the frequency varies. With implicity, it's relatively low. But really, all those side effects listed there are really uncommon. It's really very well-tolerated drug, and I think patients do quite well on all of these agents. So Darzalex, Dara, you've heard about this, alluded to already. It's now approved for newly diagnosed patients in combination with Velcade, Melphalan, and prednisone. This was based on a European study. But it's also approved in many other combinations with Revlimid, with Velcade, and with Pomalyst. So depending on what a patient needs, it could be combined with the right partner drugs. It's given intravenously. It's given weekly for 8 weeks. Then it goes to every other week for 4 months, and then eventually it goes to once a month. So it's basically a loading, and then you taper it off once the levels have been attained. This one does have a fair amount of allergic reactions, but again, quite manageable. It's up to 50% of patients can have something like runny nose, tickle in the throat, cough, wheezing. By the second dose, that drops to 4%. So it's really that first dose effect, which is why we tell patients to be prepared for a long infusion. It can be 6 to 8 hours. In community settings where that's hard to do, another way to do it is to split it into 2 days back to back rather than doing one long day. But pre-medications are given for this as well as for the first cycle, post-home steroids, post-dose home steroids. And then other than the infusion reactions, really just like with implicity, these monoclonal antibodies have very limited off-target toxicity. They really help us attack the cancer and spare the body of a lot of the other side effects. This is a slide that I think is important for patients to be aware about, which is the impact of daratumumab on blood testing for transfusions. The important thing is Dara doesn't do anything to complicate the actual transfusion. It's more of a blood bank issue. The main reason this is important for patients to be aware of, especially if you're going to multiple centers, and this came up the other day, a patient came from another institution to see me for a consultation and to transfer care, but our institution had never seen him before, so the blood bank called and said, this patient has a lot of antibodies, has he received Dara? And I was able to confirm that. So what happens is that you see in the top panel on the left that when you take known red cells and you mix them with the patient's serum, this is how we test to see if somebody has any antibodies to other people's blood cells. And you can see when you add this special reagent in the middle, in the yellow called a Coombs reagent, there's no clotting of that patient. And so that's considered a normal test. In the middle panel is a patient, let's say, who's had a lot of transfusions and they have a lot of antibodies. They attach to the red cell, and then when you do this test, they get that little clot at the bottom. And that the blood bank perceives as an antibody testing. The third bottom panel in blue is basically what happens with Dara. And it looks just like the middle panel. There is a clot. The difference is that this will occur with almost every red cell, which tells the blood bank this is not really real, it's just an artifact. And you can either strip it away or you can test patients before they're transfused. The main thing that patients need to know about is that if you ever go to another institution and they're trying to type your blood, mention that you're on Dara so that it doesn't cause unnecessary delays. What are the options after that first relapse? In our case of our concert violinist, she had the RVD induction, transplant, maintenance, and now she's had the first relapse. But what about the second relapse and beyond? What do we do there? Well, Pomalyst is an option for this setting, which is approved for relapsed refractory myeloma. It's approved in combination with dexamethasone, and as you heard, it's also approved in combination with Dara. It's given orally, similar to Revlimid, 3 weeks on, 1 week off. Again, similar to Revlimid, we need to prevent blood clots with, at minimum, aspirin. If somebody's not active, we give more aggressive blood thinning. And the side effects are really monitoring the blood counts. Those can drop with therapy, and then that week break allows the marrow to hopefully recover. And then the other side effects listed there, again, oral well-tolerated agent. As you probably all know, at the bottom is the embryo-fetal toxicity. I'm sure you all love doing those surveys, attesting that you're not going to have children and donate blood and sperm. But this all comes from the black box warning that came with thalidomide. And it's all from the back in the 70s when it was used as a sedative. So the entire drug class, we need to do that, test those Rrmm surveys. There's another oral medication called Farad or panobinostat. It's approved in combination with Velcade and dexamethasone. It's given orally every other day. And the black box warning, both on the bottom left and listed on the right, are really the diarrhea, and they can rarely cause cardiac issues. I think this drug suffered a little bit because it was paired with intravenous bortezomib. So in this pivotal study, the Velcade was given intravenously, and half the patients got it with this drug and the other half didn't. Even the people who didn't get this drug had a lot of diarrhea, because when you give Velcade IV, it gets into the body at a much higher level, and that's what causes side effects. When you give the same drug in the skin, it slowly distributes in the body, and you don't get those high levels that correlate with side effects. So unfortunately, this is the only study that was done. I do think, and I think some of my colleagues have also done studies, but for example, when we did a study with Revlimid, we didn't have a single patient that had diarrhea or had to be monitored. So I think it's important, you really need to look at the patient and the drug and the side effect profile and pick the right combinations. So what are some important pearls for these drugs? I alluded to the proteasome inhibitors, the importance of Velcade being given in the skin. Dr. Kaufman mentioned this earlier. This is very important for those patients who have a living using their hands, so concert violinists, guitarists, musicians. This is super important. And so once weekly is another option, but definitely subcutaneously. You'll probably hear more later about supportive care, but we check, for example, for carnitine levels. We've had numerous patients that have had low carnitine, and fixing that helps with neuropathy. B-complex vitamins can help, acupuncture, physical therapy. With the monoclonal antibodies, really just the pre-meds and post-meds for allergic reactions, which are primarily at the beginning. Revlimid, the IMiDs, important diarrhea. There's a drug called cholestyramine, which is a bile sequestrant drug used to manage cholesterol. We've had dramatic responses with that for patients who have that. Rashes on these drugs, that's important. It's not listed here, but unlike penicillin, where once somebody has a rash, it's labeled as a penicillin allergy, these IMiD drug skin rashes can be managed, and patients can be successfully rechallenged. The HDAC inhibitor, the diarrheal medications, monitoring the EKG. So a lot of things we can do. I alluded to this at the beginning when we were looking at the table, but what if somebody's blood counts, if somebody's myeloma is really exploding very quickly, and their blood counts are very, very low? The logistics of getting these outpatient and sometimes these combination regimens with the insurance approval and delivery can take time. And so sometimes if we really want to debulk somebody's disease quickly, we can use these 96-hour regimens called VDSEP or VVT Pace. And basically, this particular alphabet soup stands for the drugs listed there. V is Velcade, D is Dex, C is cyclophosphamide, E is etoposide, and P is platinum. And basically, those three drugs, CEP, are given intravenously, mixed and put into a bag and running continuously over 4 days. And this can be done as an outpatient. At our institution, we do this routinely. Patients go home with a little backpack pump, and then the infusion's running has to require a central line like a port or a PICC line. And these can be really effective to debulk the patient. We're going to talk later about clinical trials this afternoon. But this can be a good bridge to a clinical trial, because let's say somebody has had a lot of prior therapies. Their disease is really escalating. As you know, clinical trials, it's not you sign and then you start the next day. There's a process. And if somebody's disease is that explosive, these kinds of approaches can debulk the disease. And then the minute the numbers go up at a lower level, then we have a little bit more breathing room, because all drugs need typically at least 4 to 6 weeks to kick in. So if you're going into a clinical trial with uncontrolled disease, it can be challenging to help get, and also some of the side effects may be due to the disease as opposed to the new drug. Another way to control disease that's explosive is a salvage or second transplant, especially, again, when somebody's blood counts are low. We recently looked at this specifically at our institution, and we found that in patients who had very low blood counts, 75% of them had recovery of the blood counts such that they could go on to other clinical trials that they would not have been eligible for because of the low blood counts at the start of therapy. But the issue with the second transplant is this patient who's had its first transplant, that myeloma now has already seen the drug. So as you heard from Dr. Wiesel, transplant in a way is a little bit of a misnomer because it's really the high-dose melphalan that's causing the killing of the myeloma. So if a particular patient's myeloma has seen that drug and is relapsing, it means that it knows how to beat that drug. And so we know that for most second transplants, the remissions are about 50 to 70% of the first transplant. So you could imagine that if somebody had a very short first transplant, it may not be prudent to do the second transplant expecting a long remission. But in somebody with a long first remission might do very well with a second transplant. But even in that first patient who had a short remission, these transplants can be used successfully as a bridge to another therapy. And as I've alluded to, clinical trials are really an option for everyone. Every single drug you saw on that table in those 6 categories only occurred because of clinical trials. And so we all need to work together to get new drugs within each class and new classes of drugs. We'll talk a little bit more later about some of the exciting therapies, but venetoclax is already FDA approved for other B-cell cancers, sister cancers to myeloma. It's an oral medication, particularly has interest in translocation 11;14 myeloma, but also it's been studied in combination with drugs like Velcade and effective there as well. Selinexor, you may have heard in the news. This is made by Karyopharm, and recently there was a press release about this drug. And what's unique about this drug is who's the patient population that we were testing. So at our center, we actually accrued a large number of patients, about 35 patients on this study, and these were all penta-exposed. That means that they were exposed to Velcade, carfilzomib, Revlimid, pomalidomide, and Dara. So penta-exposed, and they had to be refractory to each class. So they had to be refractory to proteasome inhibitor, refractory to Nimid, and refractory to Dara. Why is that important? Basically, this is an unmet medical need because what is the standard of care for these patients? We don't have a lot of easy options. And selinexor, the response rate was about 25%. And while that may seem modest, that's kind of where all the new drugs enter the market. When new drugs are tested in heavily pretreated patients, typically they work in about 20 to 30% of patients. And it's important to distinguish that initial study from what may actually be used. So, for example, drugs like Dara and POM have that similar response rate, but they're given often in combinations to really augment that outcomes of the efficacy. CAR T you'll hear a lot more about, which is super exciting and I think a lot of interest. And there's also ways of doing CAR T-like therapy with what we call bispecific drugs because CAR T can take quite a bit of time to make. And again, time is an issue when patients have relapsed refractory disease. Clinicaltrials.gov is a good resource for patients and caregivers to look up. And here's some exciting studies that are going on. The checkpoint inhibitors have been a little complicated in myeloma. Drugs like nivolumab, pembrolizumab. I think we can talk more about that offline, but it again highlights the importance of clinical trials and making sure we manage adverse events effectively. There are large pivotal studies with both Dara and isatuximab combined with pomalidomide and dexamethasone. So even though we can do Pom-Dex-Dara, the pivotal study, because that initial approval was based on about 100 patients treated with the triplet, but for official full approval, the FDA requires the 2 versus 3 drug comparator studies. I think Dara, I think is an amazing option for patients. It's the easiest study I've had to consent patients to. Basically, Dara, as you know, we alluded to the IV first dose is 6 to 8 hours, and after that, median time is about 3 to 4 hours. So here we now have a subcutaneous version of Dara, which is basically injected by nurses under the skin in 3 to 5 minutes. So we are taking something that's hours to 3 to 5 minutes. The response rate seems comparable, if not maybe even slightly higher. And the side effect profile is better. Instead of 50% having allergic reactions, it's 12%. So it's hard to find drugs that are not only more efficacious potentially and safer, but also convenient. So I think this will be really great for you all to hopefully spend less time in cancer centers and do fun things with life. Carfilzomib with Dara is also being studied in a phase 3 study. The middle drug classes are already currently available. And we kind of talked a little bit about Selenex or venetoclax, but those are being combined with other drugs as well. And so I think in this last slide is basically what you as a patient, why it's important, and you heard this before, why it's important to talk about your side effects. And shown in green for each of these drugs are things that we can do to help alleviate side effects or manage patient-specific issues. So dexamethasone, if somebody has severe reflux, maybe it's not good to be giving it orally, it can be given IV, doses can be modified. Transplants can be done as inpatient or outpatient. Those drugs can come in oral or IV formulations. I already alluded to 96-hour chemo regimens can be done safely as an outpatient. Thalidomide should be taken at bedtime because it can be sedating. We talked about managing side effects like rash and diarrhea with the Revlimid. Pomalyst comes in different doses, so depending on tolerance. We covered, I think, the Velcade and Kyprolis. The Farad can be given at different schedules. And so I think the point is that if you go to your doctor's appointment and tell them what's going on, we can modify the administration, doses, schedules, combinations. That's what our job is, not to give you a combination and say, okay, see you in 6 months. And very important, I saw a lot of these questions coming up. Please also take advantage of copay assistance and travel assistance programs. Most cancer centers will have amazing nursing teams, social work team. Pharmaceutical companies have programs that they can help with. So if you're commuting a long distance, there's options. So to summarize, relapsed refractory myeloma is treatable. In fact, perhaps it's one of the most challenging treatments here we're talking about because of the plethora of choices we have. There's multiple lines of therapy. Treatment can be extended. We've had numerous new drugs, 6 in the last 4 years, more combinations, and lots of exciting clinical trials. And with that, I will stop. And what happened to her, she ended up, she had translocation 414, which can be potentially, we think the proteasome inhibitors do well there. She didn't have any neuropathy, and she started a Dara Velcade Dex-based regimen, did very well, and had a great response. So with that, thank you for your time.
One question. So we have time for one question. And along the lines of sort of what you were speaking to, we have sort of a patient scenario. So if you have a patient with underlying lung problems like COPD, are there any specific considerations for patients like that with regards to chemotherapy or antibody therapies?
Sure. There's a lot of, I think, considerations. So one of the most common complications in myeloma is pneumonia. So it's important to get flu vaccine, pneumonia 13, pneumonia 23, flu annually, those vaccines every 5 years, particularly when you have respiratory conditions like asthma and COPD. Next, you want to try to address any other things that can cause shortness of breath, like anemia, which is a big factor. Third, patients who have COPD may not be as mobile, so their risk of blood clotting might be higher. So perhaps not just aspirin, but more aggressive blood thinning if they're going to get IMiD drugs. Fourth, managing, basically monitoring closely. Very few drugs have known pulmonary toxicities, but some drugs do cause shortness of breath or cough. And so it's important to distinguish is that just a garden variety cough or is there something on the CAT scan that's concerning. So I think those are all examples of how COPD might factor in. Of course, anybody who's smoking really, this is strongly discouraged. In fact, studies have shown that smoking decreases the efficacy of Pomalyst and Revlimid. So it's really important to try to cut back on smoking.
All right. Thank you.
Thank you.